I'd like to talk to a little bit about the outcomes. In fact, I'd like to talk a lot about the outcomes because I think this is where we realize that the impact of our work is so significant. We have managed consistently and continuously to get such deeply different outcomes than most other programs that I think it's really worth stressing and reiterating how the impact of these simple measures, these small changes, these little tweaks, these ways of being have been able to transform birth outcomes in what was up till now supposedly an intractable problem. The fact that people of color, women of color, Black women, Indigenous, low income, uninsured, undocumented women were going to be at greater risk for physiological perinatal poor outcomes. We know, and obviously you do too, that that's not the case when you apply models that work. And so I want to talk about that a little bit now. There's two things that happens when outcomes improve. One, of course, the patient, mother-baby family do better, obviously, fare better, feel better, are empowered, are uplifted, retain their dignity, feel satisfied. And the other thing that happens, of course, is that the staff and the providers, the agencies, the businesses, the communities that support that change feel the same way. And I would suggest even their health as well improves, because stress is a killer. And working with this continual vicarious trauma, moral injury, frustration, anger is as dangerous to the provider as it is to the mother baby. So let's talk about the outcomes. Here's a sampling from 2018 from our Easy Access Clinic in Orlando. And that year we had 639 patients that we saw in the clinic. The Easy Access Clinic provides care for people who are choosing hospital by their own will, not because they've been forced to or because they have no other options. But when given options, they choose a hospital delivery because that's their choice. That's it. So the Easy Access Clinic is there to support outpatient care for prenatal, outpatient care for postpartum, interconception, and so on, and not to do the actual physical delivery. Although that's possible when there is a continuity model of an Easy Access Clinic. But what's really significant about these outcomes is that in the absence of being the delivery providers, we still get these changes. 639 people were seen. We had 425 complete data sets. So of those 425, the average gestational age was 39.4 weeks, lowest gestational age was 26.1, highest was 42.1. Obviously, by the time they hit the 42, we're sending them in for induction. That's why no one's really gone past that. And again, they are hospital bound on purpose and by their choice. Average birth weight, though, is 7 pounds. At the 2018 stats, 5%, which was 21 babies, were of low birth weight, of which 2.8%, which were 12 babies, were less than 36 weeks. All babies survived in those categories. There was one fetal demise at 26 weeks gestation, premature birth, and a baby that didn't make it. And 82% of the people in this data set had their babies had breast milk as the first food. This is very typical and common for us. So in a volume clinic where we're not delivering the baby, seen by midwives or nurse practitioners, along with the perinatal support team, this is what happens. The majority of the women in the practice are of color, and that's important. So let's look at the data. The original set that we did was done back in 2006, 2007. And it was the first time we set out purposefully to capture what was going on. We knew what was happening. We already knew, we could tell that our model was making a tremendous difference. But in 2006, we were funded to do our first study, and we did a prospective study of 100 women in the Easy Access Clinic. So basically, the women were enrolled in the study, if they consented, and we waited to see what happened. And at the end of this 100 women, as the last one delivered, we collected the data, and this is what we got. So I'm in Orange County, Florida. And here's the comparison with what happened with the JJ women in the Easy Access Clinic population. Again, prospectively enrolled and compared to whether they, race by white, Black, or Hispanic. So the total population, you can see this, the figures here, that around about a 15% prematurity rate when we include everybody. And so the JJ clients had 4.7% of prematurity that year. The white women constituted most of that, as you can see. But look at the rate for white women in Orange County and in Florida. Pitiful. Prematurity. But when you see the rate for Black women, it really blows your mind, because at that point, we were at 1 in 5 Black women in the state of Florida and in Orange County were having a preterm baby. And in our cohort, we didn't have one single Black baby born prematurely. Then we looked at the Hispanic rate, which is about 15% average again, and no Hispanic babies were born that were premature. That set us off on a trajectory, as you can only imagine, because we were just thrilled with those results and we were able to say our model works. Over the years, we've continued to collect, and we are very much on target pretty well. We have, an extremely low percentage of prematurity, if we have any, or extremely low percentage of low birth weight babies. This was a different study. There were, I think, 240 in this cohort, Easy Access Clinic patients who choose hospital birth. Of all the women, again, still 15%. So this is 7 years later, but still holding on with this 15% prematurity in Orange County. And we were, again, under 5% for the whole group. Once again, you see the white women populating that statistic more so than the women of color. Once again, nothing, 0. This is significant because prematurity seemingly is mitigated by applying this model, not just reduced, eliminated. This is significant. If you know anything about the government's Healthy People goals that come out every decade, the Healthy People 2010 goal was to eliminate racial disparities. Here we are. We did that. Okay, so let's look at the 2017, where things were a little bit different. At this point, the clinic was quite large, and also, we had a different set of staff, and we were working on some different approaches. I think that's reflected in these statistics, but it also speaks to the fact that even with different changes and challenges, we were still, really making a difference in terms of prematurity. So in this case, this year, we saw an uptick in the Black prematurity, but still practically half of what the county and the state were doing. Once again, white women still had a reasonable amount of premature babies. And in this case, we had Latinas with some premature babies. The point, though, is that we were applying this JJ model consistently. And as we've continued to develop it and work with it, we've been able to figure out the particular pieces, which is why we've codified it into these training models so that you can follow it exactly and get a similar, if not better, or the same outcomes. So looking at this last one, this is the same with low birth weight, babies weighing less than 5 pounds, 8 ounces. And again, white babies still there showing, presence. The Black babies were similar to the premature babies in the same 2017 group, and the Latinas. I think it's important to point out that at the end of the day, we know that we can say categorically that the impact of applying the JJ way model is going to always have some statistical significance for improving, if not eliminating, poor birth outcomes in African American, Black, Indigenous, people of color. And that is what we're doing here. Thank you.